All right, can everybody see my screen? Awesome. Okay, so if you have a question as we're going through this, feel free to type it into the chat box. You can turn your mic on to ask the questions, but just make sure you mute yourself afterwards. It just becomes cumbersome when it's too many noises going on. Okay, so this slide here, it outlines the flow of blood through the heart, right? And while we're going through this, I'm going to mention to you guys a couple things to be aware of when we before we get into the cardiac cycle, because the cardiac cycle, it really tells you how the movement of this blood through the heart is governed, right? And it's based on pressure changes. Okay, so I'm going to emphasize some of the pressure differences as blood is coming into the heart, moving throughout the 4 different chambers. Okay, by now you guys should have a decent understanding of the different chambers of the heart. Here we have the right atrium, right ventricle, left atrium, and exiting out of the heart are the great vessels. You have the pulmonary trunk, and you also have the aorta. All right, so the aorta kind of just loops behind the pulmonary trunk, and it's exiting out from the left ventricle. You guys should be good with that, right? If you aren't good with the internal anatomy of the heart, I strongly advise getting that down, right? That's like the bare minimum of what you should know, okay? So when blood enters into the heart, it enters into the right atrium, right? And there's a couple vessels that drain into there. We have the superior vena cava and the inferior vena cava, right? And you also have the coronary sinus, okay? This is a drainage point from the blood that is coming from the heart itself, right? From the myocardial layer of the heart itself. So you know that blood is draining into the right atrium, and as blood starts to drain into the right atrium, think about what might happen to the pressure here. What do you guys think would happen to the pressure on the walls of your right atrium as blood is kind of just draining back into the heart, particularly here in the right atrium? What's happening to the pressure in the right atrium? It starts to increase, all right? So when you take a look at the valve that is stopping the blood from going down into the right ventricle, at this point, that valve is closed, right? So that closed, pressure starts to build up in here, right? Keep that in mind, just that the phenomenon behind the pressure accumulation, okay? So once again, if you guys just please mute yourselves. Make sure that, there we go. Okay, so as the slide shows here, deoxygenated blood enters into the right atrium, and that's important to also know that it's deoxygenated blood, right? So it's blood that has dropped off its oxygen to the tissues, wherever it may be in the body. But at this point, it's deoxygenated and it's coming into the right atrium via these 3 vessels, right? So it starts to accumulate here. Blue is usually used to indicate deoxygenated blood, right? So just keep that in mind, especially when you're seeing these diagrams. Blue indicates deoxygenated blood, right? And then we keep moving. At some point, what ends up happening is this blood accumulates so much here in the right atrium that it causes this valve to open up. What is the name of this valve here? I know. What's this valve? This first valve. Something you guys definitely should know, right? Being able to trace the perfect. Good job, guys. So, sorry, I guess I should allow you guys to type it in before asking and then expecting an answer right there. But yeah, it's a tricuspid valve, right? It's one of the 2 atrioventricular valves, the AV valves, right? The other one is right here. They just separate the atria from the ventricles. But while we're focusing here on this right side, right, let's just look at this one. This is the tricuspid valve, right? And eventually, as the pressure builds up in your right atrium, it opens up, right? When it opens up, you end up sort of draining that blood into the right ventricle, right? And we'll talk about exactly how this occurs when you get to the cardiac cycle, because this blood that seeps down into your ventricle, it does exactly that. It seeps down for the most part, right? Only about 20% of it actually gets forced down into there, but we'll take a look at that in a little bit, right? So blood makes its way down here into the right ventricle, and now as blood starts to accumulate here in the right ventricle, assuming that this is shut, right? And valves prevent backflow, so you assume that this is also shut now. We think it's going to start happening here in the ventricle with the pressure. Once again, it's going to start to increase, right? So as blood starts to accumulate into the right ventricle or in the ventricle in general, because it's the same thing that's happening on the other side, We're just looking at the right side right now, okay? So blood starts to accumulate, and the pressure that the wall of that ventricle feels starts to increase, and therefore, as pressure increases, it eventually causes this valve, which is known as, what is this valve known as? The valve that separates your pulmonary trunk, this trunk here, from your right ventricle. What is this valve known as? It's an important point to know. Not the bicuspid, not the bicuspid. All right, give me the general term for it. It's the pulmonary valve. Now, if you were to give me the full name of this valve, what would you call it, right? Give me the category of valves that this valve would fall under. Because we have semilunar, right? So it'll be the pulmonary semilunar valve, all right? Keep that in mind. If you are going to identify any of these valves, make sure to identify them thoroughly, all right? If you just call it a semilunar valve, well, this is one of the two semilunar valves, right? The other one's right there. Well, I guess it doesn't really show up in red, but it's the one that separates the left ventricle from the aorta. It's also a semilunar valve. But we distinguish the two different valves from one another by giving it a specific name. This is the pulmonary semilunar valve. Pulmonary, there we go, semilunar, right? And if you completely forget that this is a semilunar valve, just look at it, right? It looks like two crescent shaped objects coming together, right? So going back to the flow of blood, right? As blood starts to accumulate here in the ventricle, in the right ventricle, it will eject the blood out from the pulmonary trunk, out into the pulmonary trunk rather, through the pulmonary valve, right? Or past the pulmonary valve. And eventually, where is this going to take us? Where is the pulmonary trunk ultimately going to lead us down to? You can see that on the slide. It'll ultimately take you to the lungs, right? So once again, just keep in mind that this blood that is flowing on this right side was deoxygenated when it came in, deoxygenated up until this point, still deoxygenated, and then it'll make its way down to the lungs. And what does it do at the lungs? Why would you want to send your blood? Why would you want to send deoxygenated blood to your lungs? To go pick up oxygen, right? Like you equip it with oxygen that it needs, and it comes back up via the pulmonary veins, right? And I guess I should have mentioned that, jumping back a little bit, that deoxygenated blood gets sent to the lungs via the pulmonary arteries, okay? So pulmonary arteries, right? They carry, there we go. They carry deoxygenated blood to the lungs, right? And the truest definition of an artery would be that it carries blood away from the heart. So just keep that in mind if you're trying to identify what this structure here would be. If you know that it's carrying blood away from the heart, it's an artery, right? A lot of people confuse this and say it's a pulmonary vein. As you're entering in, just make sure your video is off as well as your audio. Be mindful of that. All right, so the blood picks up oxygen from the lungs, comes back into the heart via the pulmonary veins now, okay? So these veins, the truest definition of veins is that they're going to bring blood to the heart, okay? And at this point, these pulmonary veins are carrying oxygenated blood, right? And oxygenated blood is usually going to be shown in red. So from the lungs, you drain into the left atrium now, okay? And a similar phenomenon occurs here, where from the left atrium, as blood starts to accumulate here, let me change this pen color. As blood starts to accumulate here, you end up with, let's go so as blood starts to accumulate here, you end up with a higher degree of pressure exerted on the walls of that left atrium. And then that blood ultimately seeps down here into the left ventricle. And it does exactly that. It seeps down. 80% of it seeps down, and 20% is actually ejected down here by way of contraction. Okay. Eventually, this ventricle, it recognizes the pressure, or it starts to feel the pressure exerted by the blood that's accumulated here. And once that pressure gets large enough, this ventricle is going to contract and force the blood through the next semilunar valve. And anybody know the name of this valve here? It's on the slide, but you should be familiar with this one too, okay? This is the aortic semilunar valve. You could just call it the aortic valve as well. That's sufficient, but if you want to be thorough and complete, I would write aortic semilunar valve. All right. Now that blood gets ejected through this valve into the aorta. All right. So keep this in mind right here that your left ventricle, the myocardial layer of that left ventricle is so thick that, or in comparison to your right ventricle, um, it and it needs to be in order to generate the pressure for that blood to travel through your systemic circulation. Okay. Now, as that blood makes its way out of the heart into the aorta, right, what do you think is going to happen to the pressure here? And this is kind of like an extension that's going to lead us into the cardiac cycle. So as blood starts to exit out from here and into the aorta, what do you think is happening to the pressure that the aorta feels? It starts to also increase, right? Now, excuse me. As this pressure increases in your aorta, right, the wall of your aorta starts to recognize this pressure increase, right? The pressure at some point is going to be higher here and lower here, right? We okay with that? What do we know about how pressure dictates the flow of blood? In which direction would pressure, or does blood flow given the difference in pressure? Like if you had an area of high pressure and an area of low pressure, right? Which direction would blood want to flow? It flows from area of high to low, right? So what I was saying was that eventually, as blood gets ejected out here, there's an increase in pressure in this region that it surpasses the pressure that the ventricle feels, right? So blood is going to want to flow back this way. Why can it not flow back into the ventricle? Circle the answer, but go ahead and answer that. Why wouldn't? Because the aortic valve, right? The aortic valve, it slams shut when that blood tries to make its way back, right? That point where that pressure gets higher in the aorta, higher than it is in the left ventricle. At that point, as blood tries to make its way back, it's prevented from doing so by the aortic valve. It slams shut and it creates that second heart sound, right? When this closes, this is that dub sound, right? So if the closing of this valve, right, or this and this one, right, because that's happening simultaneously, right? If the closing of these two valves create the dub sound, what do you think the lub sound is going to come from? Lub and dub, that's your heart sound. So if the semilunar valves closing cause the dub sound, it's the AV valves that cause the lub sound. Careful, careful, Jasmine. You said the pulmonary valve, but the pulmonary valve and the aortic valve, they open and close simultaneously, right? So if you noticed, what's occurring here in the right side of the heart, it kind of mirrored what was going on in the left side of the heart, right? It's exactly what is happening here, right? You end up with a mirror image of what's going on either side, and it's happening simultaneously, right? So as your AV valves open and close, right, this happens simultaneously, right? These have to remain closed at that point. And then when your semilunar valves close, well, that also happens simultaneously, right? So AV valves open and close simultaneously, and semilunar valves open and close simultaneously, right? And it happens one after the other. Okay, everybody okay with that? I think I might have jumbled my words there, but I can go over that again if you need to. All right, so everybody okay with the flow of blood through the heart? All right, eventually that blood is gonna, when it gets into the systemic circulation, it's gonna make its way through the various different branches that project off of the aorta. What is that first branch right here? What's that first branch? Projects off the aorta. The brachiocephalic, right? Keep that in mind, right? Brachiocephalic. Uh, and then you have the left subclavian and left common carotid. I'll leave that up to you guys to determine which one that is. Don't want to get into all the vasculature just yet. Okay, so that's my slide on blood flow through the heart. This is available to you guys in files. I believe it is there. I think I put it in there. I'm not sure. I can in a little bit, but if you want to review over this, the slide does help out. Or it's helped me out. So maybe it might help you out. All right, so let's take a look now at the cardiac cycle. Right. Before I proceed, is there any questions on what we just spoke about? Perhaps from your study guide in regards to your okay, so let's keep moving. Okay, let's jump to. Let's doing this. There we go. Let's jump ahead to the cardiac cycle then, all right? Because it relates to what we just spoke about here. Okay, I'm going to start off down here because the images really help in understanding what we were just seeing earlier on, right? And because of the fact that this is a cycle, right? There's really no end or beginning. You just pick a starting point and you can move on from there, right? So just to help make sense of this image here, I personally don't really like the images that you use here, but this is continuous with this, right? So this is just kind of leading into that there, okay? Let's define some terms really quickly. You know that you have systole and diastole, right? Generally speaking, what is going on during systole? Regardless of whether we're talking about atrial or ventricular systole, what's going on during systole? Contraction. Good job, man. Contraction, right? And during diastole, what's going on, regardless of whether it's atrial or ventricular, this is when it's relaxing, right? So relaxation. In regards to pumping blood out of the heart or through the heart, just pumping blood, right? Which of these would be associated with the pumping action? Contraction or relaxation? In order for you to be able to pump blood, you'd want the heart muscles to contract, right? So contraction, when you see systole or contraction, think about the fact that these chambers might be forcing blood to move from one place to another, right? Depending on which chamber you're looking at, it could be uh, further along in the heart or out of the heart, right? So this is associated with the pumping action of the heart. And the relaxation, we associate the relaxation or the diastolic phase more with filling, right? Now, we can attribute these qualities to both the atria and the ventricles. However, they don't happen entirely simultaneously. When the atria are in systole, when the atria are contracting, right, the ventricles are in diastole, right? They're relaxed. And that's generally true because there is some overlap, right? And vice versa, right? When the ventricles are contracting, then the atria are generally in the relaxed state, right? And then you do end up in a period where everything's essentially relaxed. We call it the relaxation period, right? So there is a period of time where everything is in diastole, okay? In general, right, your heart spends about 2/3 of the time in diastole. It's more relaxed than it is spending time contracting, right? So a third of the time in systole and 2/3 of the time in diastole, right? Keep that in mind. So we talk about mean arterial pressure, that comes in handy, okay? So about a third of the time you're in systole, 2/3 of the time you're in diastole, okay? Irrespective of whether we're talking about the atria or the ventricles, we'll deal with that in a little bit, all right? Let's take a look at these images then, all right? Is everybody okay with the terms I've defined here and what they refer to? Traction, relaxation. Okay, all right, keep moving, okay? So let's just pick a starting point. Let's start right here. Ventricular filling, all right? We'll start with ventricular filling. When the ventricles are filling, this is occurring passively for the most part, right? What is happening here is the blood that was filling up here in your right atrium, as well as in your left atrium, right? The blood that's filling up in these regions, it's essentially just seeping down into the ventricles, right? The associated ventricles here. 80% of that blood that comes into here is going to just work by gravity, right? Now, eventually, what ends up happening is you enter a phase of atrial contraction, right? And this is the point where about the remaining 20% that stays in here is ejected into the ventricles, right? So atrial contraction. Let's associate some of those terms we just spoke about, right? During passive ventricular filling, right? you are at rest for both of your atria and your ventricles, right? The atria are not doing anything, they're not contracting. The ventricles are just filling up, so they're not contracting, right? Because if they were contracting, they'd be ejecting blood out, right? But they're not. Everything's kind of just relaxed, right? Blood is coming in and it's just seeping down into the ventricles, right? Are you okay with that? So at some point though, right, what ends up happening is the atria, they contract, right? So the atrial contraction phase, we associate this with the P wave, right? You guys remember on your EKG, you had the P wave, and you had the QRS complex, and then you had the T wave, right? This is the P wave. We associate this with atrial contraction because remember, this was atrial depolarization, right? So atrial depolarization. Whenever you see muscle fibers depolarizing, think of them as contracting. So atrial depolarization is occurring here, right? Then, and we associate this region right here when you enter into atrial systole. The pink is systole, right? I should really just say it here as well. Atrial systole. And it ejects out the remaining 20% of the blood that's here, okay? When it does that, the pressure down in your ventricles, it increases to the point, right, where the blood wants to flow back where it came from, right? It just wants to flow somewhere, right? It wants to either flow back where it came from or potentially out of the heart. It can't flow back where it came from, right? So it shuts the door behind it, right? Right here, there's enough pressure that the ventricles are feeling as a result of that ventricular filling that they shut the door behind them, or the blood shuts the door behind it, right? And these valves close. This is that lub sound right here, right? So this is where we associate that with the lub sound. And if you're looking at the entire diagram, it's a couple slides prior to this, you'll see that the lub sound is associated with this right here, okay? So far, so good? Everybody okay with what's going on here? So because we're in a contraction phase, and when we're talking about the contraction of the ventricles here, we're in ventricular systole, right? So ventricular systole is associated with ventricular contraction. So as these ventricles start to contract, right, space down in here gets smaller and smaller, so the pressure increases, right? The pressure inside these ventricles increases. As that pressure increases, that blood is going to want to flow somewhere, right? And the only way for it to flow is out of the heart. We call this phase ventricular ejection, okay? So going back to this term here, isovolumetric, this term just means that the volume stays the same, right? I mean, that kind of makes sense because the only thing that you're doing here, right, there's no more blood coming in. You've closed the valves. The AV valves are closed now. So there's no more blood coming in. It's starting to contract, right? So the pressure is increasing, right? The only thing that's changing here is the pressure. The pressure reaches to a point where it opens these valves up and the blood flows out of the heart. So the ventricles contract, flowing the blood, causing the blood to flow out of the heart, right? Ejecting the blood out of the heart. From the right ventricle into the pulmonary trunk, from the left ventricle into the aortic valve, or into the aorta, right? Now, eventually, right, what ends up happening here, you reach a point that's known as isovolumetric relaxation, okay? So isovolumetric relaxation this occurs when the ventricles begin to relax, right? Because that blood, when it's made its way out of the heart, right, that pressure is relieved here. So as that pressure begins to get relieved, those ventricles start to relax. When they begin to relax, right, the pressure ultimately becomes lower here, it says low, right, and higher out here. And that's what causes those um, valves to slam shut because the blood's going to want to flow back into the ventricles due to the pressure gradient. Can't do that though because those are one-way valves, right? So it slams the door behind itself, right? The blood that leaves out of the heart slams the door behind itself, and that causes the dub sound to be produced, right? So we just related the cardiac. That completes one cardiac cycle, by the way, right? And associated with the cardiac cycle are these two beats, the lub dub beats, right? This happens about 75 times per minute for a healthy individual, a non-athletic healthy individual. But this is the cardiac cycle, right? We'll take a look now at the entire diagram here. and relate some of these terms, right? Now that you guys have an idea of what pressure or how pressure governs this process, talk about some of these other terms that we're seeing here, right? This diagram here, what it really shows is the volume changes, shows the pressure changes throughout the heart, also shows you the sounds, right? And it relates to what we know about the physiology too. So, are we okay to start on that, or anybody want to talk about the cardiac cycle in a little bit more detail, or have any questions? We good? No? Okay. How many people do we have here? Nice, about 15 people. Let's relate it to the volume really quickly, okay? Because the volume does come in handy, and we do need to know about the volume changes that are occurring in the chambers of these heart of the heart, right? These different chambers. So when you see this region here, this purple region, this is associated with the start of ventricular systole and the end of ventricular systole, right? So there's a difference in how much volume of blood is in your ventricles at the end of diastole, or in other words, at the beginning of systole, right? When diastole ends, when relaxation ends, it's marked by the beginning of something else, right? So you end diastole, you start systole. At that point, right, there is a certain level of blood or certain volume of blood within your ventricles. We call this the end diastolic volume, all right? End diastolic volume is how much blood is loaded into your ventricles. And then at the end of systole, the end of ventricular systole, at the end of ventricular contraction, in other words, you assume that there's blood that left the ventricle, but there's some blood that remains in the ventricle. We call this the end systolic volume, all right? The difference between these two numbers gives you the stroke volume, right? So if you were to define stroke volume, you define it as how much blood leaves the ventricles or how much blood is ejected out of the heart per beat, right? Another way to look at stroke volume is, let's say that you left your house this morning and you put 10 cookies in a jar, right? 10 cookies in a jar. You came back home and there was only 2 cookies left, right? And you did some math in your head. You looked at it. You said, "All right, I left 10 cookies here, and there's only 2 remaining, right? That means somebody ate 8 cookies. That's how much left the jar, right? So how you calculate stroke volume is end diastolic volume minus end systolic volume, right? How much you loaded into there minus how much left. So Teresa's asking, EDV is preload and ESV is afterload. No, although I can see where you can confuse the terms for that, that's not where afterload and preload relates to, okay? We'll talk about that in just a little bit. Might be getting a bit ahead of this, but it relates to stroke volume, and we'll talk about what preload and afterload is in just a little bit, all right? Does everybody understand how we calculate stroke volume then? Right? So end diastolic volume minus end systolic volume, right? Um, Given the nature of like these online sessions, like I can't really tell if what I'm saying is something you guys already know. So if I'm just going over things that are, you feel that you already know and giving it too simple, stop me and we can get into some of the more nitty-gritty stuff. But if it's okay, I guess I'll just continue, right? Right. Yeah. So I guess it's strange talking to like a chat box, right? But hey, gotta do what you gotta do, right? So EDV minus ESV will give you your stroke volume, right? And stroke volume is generally about 70 milliliters per minute, or per beat rather, right? Careful, I made that mistake that a lot of people are prone to making. Stroke volume is how much blood leaves a heart per beat, all right? When you talk about how much volume leaves a heart per minute, we're talking about cardiac output. We'll get to that in just a little bit, okay? Moving on here into some of the other features of this diagram. Here you can relate the heart sounds, right? Be able to familiarize yourself with what causes the heart sounds, right? It's the closing of the valves. Okay? And right here, this part of this diagram This just indicates to you the pressure changes within different parts of the heart, right? So you're looking at aortic pressure, left ventricular pressure, and left atrial pressure, right? And you can associate this with what is going on in the cardiac cycle, right? So aortic pressure, it's by and large for the, it's consistent here during atrial systole because you're not really at that point yet to be able to inject blood into there. But what you're seeing is slowly that blood that starts to accumulate into your into the ventricles, right? It's slowly rising here. Here's the volume. As that blood starts to accumulate, you start to increase the volume in your ventricles. And this right here, this just indicates to you the remaining 20%, right? So once that remaining 20% is ejected out, the bicuspid valve will close. Also the tricuspid valve, the AV valves will essentially close, right? This is just dealing with the left side. But you can assume that both of those valves, tricuspid and bicuspid valves, close right there. There's that first sound, lub sound. And then the pressure within your left ventricle starts to rise, right? Because as that starts to contract, keep in mind, we're getting into contraction now, right? This deals with as that starts to contract, the pressure starts to increase. When it overcomes the pressure that the aorta is exerting back into the left ventricle, that's when you have ventricular ejection, right? So if you came down here, it's when you enter into the ventricular ejection phase. Okay, you eject that blood out. What you can see here is the volume starts to decrease as well, right? So as you start to eject it out, the volume is going down, right? So during the ejection phase, that's when blood starts to leave out of the ventricle. And then that pressure starts to come further and further down. Eventually, it uh, as soon as it becomes lower than that of the aorta, it slams the door behind itself, right? So the aortic valve closes, and obviously on this other side, the pulmonic or pulmonary valve also closes. But that closing of that, sorry guys, go back, there it is. The closing of that valve, it closes with so much force that it generates a pressure rating right here. And we call this the dichrotic notch, right? Dichrotic wave, right? And that's where the dub sound is, okay? Excuse me. Then you end up in a relaxation period where ventricular filling is allowed to occur again, right? That's the cardiac cycle, right? And how to read this diagram really, right? It may not register immediately. Maybe there are some things that you're still unfamiliar with on here, but if you can read this, you have a good understanding of what's going on in the heart, right? If you can associate it with the pressure changes and what causes blood to flow through the heart, you have a good understanding of this, all right? With the interest of time, I'm open to some questions on that. You guys want to talk about it a little bit more? By all means. Anybody? Maybe I should just allow like the mics to be on, but then I'll hear like dogs barking and stuff. So uh, if you are to prepare, if you are trying to prepare for the essay questions, something like this could be fair game, right? However, um, it's up to you how you study for it, how comprehensively you study for it. These physiological processes, they're pretty much fair game, right? Focus on something like the cardiac cycle, focus on the conduction cycle throughout the heart, right? So the intrinsic conduction cycle is something that could also be tested because it relates to this. EDV is end diastolic volume, all right? It's how much blood is loaded into the heart at the end of relaxation, right? So you guys know that, relaxation is when blood starts to fill in to the ventricles, right? But how much is loaded in at the end of relaxation, right? Or just at the beginning of systole, right? Right before it starts to contract, how much blood is there, right? So it's like right before you leave the house, how many cookies were in the jar, right? And you left your house and then somebody came and ate cookies, right? That's how many left, right? That would be this phase right here. And then you came back home and you saw that there's only a couple remaining. That's the end systolic volume, right? So at the end of contraction is systolic volume. At the end of relaxation is the end diastolic volume. Stroke volume is EDV minus ESV. Okay. All right. Any other questions on that? Now, cardiac output is something that we can also talk about. And I think that is on the slides. Yeah, there we go. On this slide here, right? Cardiac output, something important to know because when you talk about cardiac output, it relates also to the blood pressure that we'll see later on in chapter 22, 23, I believe, the respiratory system. So something like this, definitely dedicate this to memory, right? Cardiac output, the way you calculate it is the stroke volume times the heart rate, right? Heart rate's pretty easy to get. You can listen for this. Auscultation can tell you your heart rate. You can figure that out by your pulse rate as well. So once you have your heart rate and you know your stroke volume, right? And stroke volume, once again, is calculated by EDV minus ESV. If you know the values for these units, you're able to calculate your cardiac output, which tells you how much blood is ejected out of the ventricles per minute, all right? Now, your heart rate, obviously there's a number of things that can increase your heart rate or decrease your heart rate, right? But your stroke volume here, there are a couple factors that can impact your stroke volume, right? And that's where we get into preload, afterload, and contractility, right? But be able to calculate this, okay? You guys should be able to calculate cardiac output, EDV minus ESV, to give you your stroke volume. So let's just say that this was something like 70 milliliters per beat. And your heart rate, let's just say that it was around 75 milliliters per, or sorry, beats per minute. Late for me, guys. Super late. Beats per minute. Okay. Well, basic arithmetic will tell you that these cancel out. Beats cancel out. Anything that shows up on the top and on the bottom will cancel out. So you're left with 70 times 75. I think that's like, is that like 3, 4? No, almost 3 liters, I think. 70 times 75. Somebody wants to do that. I'm definitely not doing that kind of math in my head right now. So I would just pull out a calculator and do it. 70 times 75. Yeah, about 5. Oh, I was way off. 5,250 milliliters per minute, right? That's 5 liters per minute. So if you think about it, this is just the average numbers right here, right? 70 milliliters per beat would be like an average non-athletic adult who just at rest, pumping out about 5 liters of blood per minute. That's a lot of work that your heart has to do if you think about it, right? You're able to pump out 5 liters per minute. Now, if you think about it, beyond that, right? Let's say that if you were to increase your stroke volume, let's say your heart was able to pump out more blood with the same amount of beats, right? As the case would be with an athlete or a trained athlete, right? You could reach up to like 35 liters per minute, right? But in non-athletic people, it's about 4 to 5 times. The maximum amount you can reach is about 4 to 5 times this, right? So theoretically, you can get anywhere from 25 liters to 30 liters here, right, per minute, which is insane. But if you were like a trained athlete, you can get up to like 35 liters per minute. So how would you increase cardiac output then? What are some factors that could increase cardiac output that don't involve heart rate, right? Because heart rate can be increased by just exercising. What are some things that can increase your stroke volume? You want to take a guess? I don't expect you to know this right now. If you haven't covered it, maybe if you covered it already and you want to take a guess. But I mean, this is something you guys should know. So, what impacts your stroke volume? I think it's on your study guide. It's a bullet point there. So, drugs. Drugs could do it in some form or another. There's your thyroid hormones, things like that. But think about how much blood is coming into the heart, right? What do we call that? Yeah, Irene, you said preload, right? So preload relates to how much blood is loaded into the heart, right? We talk about preload. It's it's essentially, I'll give you guys a working definition that doesn't um, overwhelm you, right? If you were to, it's related to like the ventricle and how much it's stretched, right? That's what we relate preload to. So this is an all-encompassing term because when you focus on the stretch that the ventricles exhibit as a result of the blood being loaded into them, right? You can infer that the more blood you got coming in into the ventricles, right, the more stretch or the more stretched the ventricles are, right? So stretch of ventricles. That's probably the best working definition you can use here because you can account for what will cause that stretch to increase. So um, if you increase preload, right? So, Jules said increased preload, decreased afterload, and increased contractility will increase stroke volume. Yeah, good job. All right, so let's talk about that then, right? And first, let's just define these here. Afterload is the pressure that your ventricles need to overcome in order to eject the blood out of the heart, all right? So let me just jump back to the diagram, the cardiac cycle diagram. Here. When blood is leaving out of your heart through the aorta, right, there is a pressure that the aorta is exerting back onto the blood that's coming here, right? In order for these valves to open up to allow for you to eject that out, in order for ventricular ejection to actually occur, this pressure that is present in your aorta needs to be overcome, right? Call this the diastolic pressure, right? I mean, this is your diastolic pressure at the end of um, systole. The pressure that this is experiencing would be your diastolic pressure. This needs to be overcome in order for you to be able to eject it out of the heart, right? So if you increase the diastolic pressure, right? If you took somebody's blood pressure and you saw that it was an increased diastolic pressure, would that make it easier or more difficult for you to be able to eject blood out of the heart? There's more pressure to overcome, right? Therefore, it would be more difficult for you to eject blood out of the heart, and therefore your ejection phase will be shorter, right? Let's jump back to the slide here and talk about contractility as well, right? And we'll relate all three of these in a second, okay? So this is just how much pressure needs to be overcome, and so the pressure that needs to be overcome in order to eject out of the heart, right? In order to carry out ventricular ejection, right? Preload, we said it relates to the how much stretch is induced on the ventricles, right? So stretch of ventricles. And contractility is how strongly the ventricles contract, okay? So these two here, they kind of go hand in hand, because if you stretch out the ventricles more, it has a length tension relationship in that the more it's stretched, the stronger it's going to contract. And that's what the Frank-Starling law really relates here, okay? So it's kind of like a rubber band, right? So it'll recoil back and causing the ejection to be to increase if you load it up with more blood into your ventricles, right? So when we're talking about how much blood is coming into your ventricles, one of the main things that affects how much blood is coming into the ventricles is venous return, right? So venous return is just how much blood is coming back to the heart. If you increase how much blood is coming back to the heart, you therefore increase how much blood enters into the ventricles, and therefore you increase preload, which therefore increases contractility, and then you will increase the stroke volume as a result, all right? And that's exactly what Jewel mentioned in her comment. You increase preload, therefore you will increase contractility, right? But if you increased the afterload also, right, well, then you have to overcome that. So if you want to increase your stroke volume, you increase preload, which will therefore increase contractility, and you will decrease the afterload, right? Now, there are ways you can do all of this, right? How you can decrease the afterload and how you can increase contractility. There's drugs that are available to you. There's hormones that your body naturally produces as a result of this, right? So contractility, for instance, you could administer ionotropic drugs to cause that to increase. Sympathetic stimulation, so in a fight or flight response, that will increase. Um, Negative ionotropic agents, right, would decrease it. So just some to give you an idea of how this impacts stroke volume, which would therefore impact your cardiac output ultimately, right? Um, so the factors that go into stroke volume. You okay with that? For these terms, really just be able to define them. And like I said, preload and contractility, if you define these um, generally and have a working understanding of it, then you can understand how they affect your stroke volume, right? So, the book gives you some very um, complex definitions for this, or some things that go into more details that can confuse you, but just define these very generally and it'll give you a better understanding of it. I forgot who had the question yesterday dealing with preload, afterload, and contractility. But does that clear the air a little bit? If you are here, assuming you're here, you're not. Yeah, got a yes. All right, awesome. All right, let's keep moving then. Okay. How you can regulate your heart rate, right? And so this is the other side of your cardiac output, right? So here's cardiac output is equal to stroke volume times heart rate, right? Stroke volume we could impact it by preload, contractility. That says contractility, and then afterload, right? These are the different factors that control stroke volume, and then heart rate is impacted by various different factors. Your autonomic nervous system, it doesn't set your heart rate, but it can control it, right? So involuntarily, you can regulate your heart rate by parasympathetic and sympathetic innervation. The vagus nerve, right? That comes to mind. Think about that. Vagus nerve. Keep that in mind. And different hormones, right? So you have like you have epinephrine, norepinephrine, things like that. Different ions, right? So if you have an increased extracellular potassium levels, you can impact heart rate. But yeah, generally you get a feel for how heart rate can vary depending on plenty of different things, right? So if you wanted to really regulate your cardiac output, right, and you wanted to have more control over it, one of these might be a better sticking point for that. Okay.